Welcome, everyone. While we wait for folks to join us, we will get started in just a few moments. Greetings, everyone, from Austin, Texas. I am Sherri Greenberg, and I am a professor of practice and a fellow of the Max Sherman Chair in State and Local Government at the LBJ School of Public Affairs. I also have the honor of serving as chairperson of Central Health, which is a local government entity here in Travis County, providing healthcare to people of very low income and without insurance. This year, the LBJ School turns 50. Throughout this landmark year, we celebrate the LBJ School's half-century of impact, not just within the walls of academia, but in the arena. Our LBJ In the Arena virtual series brings together world-renowned policy experts and frontline stakeholders to serve and inform us on a variety of topics. And we are very fortunate to have experts with us here today. We will be taking questions at the end of the session through the Q&A feature, not the chat feature. The Q&A feature is at the bottom of your screen. Thank you for joining us. Please remember this video session will be up on the LBJ School In the Arena website on Friday, along with deeper dive materials for you. A reminder that registration is now open for the LBJ School's 50th anniversary forums, which occur on October 5th and 12th at 7 p.m. Central Time. Guests include Stacey Abrams, Darren Walker, Melinda Gates, Admiral William McCraven, and more. You can see the full lineup and RSVP at lbj50.org. We look forward to seeing you next week, where we will be doing a post-debate analysis after the first presidential debates. Now I would like to introduce you to Michelle Circa. Michelle is a second-year Master's in Public Affairs student at the LBJ School. During her time at LBJ, she's worked with the team to make recommendations for improving the state's driver's licensing program. Before graduate school, she worked at US PIRG, advocating for more equitable tax policy and more transparent budgets and spending on the state level. Now, she's going to tell us about the project she's working on this year with me and James Snow around using smart city technology to better serve people experiencing homelessness. Michelle?
Thank you, Sherri. Thanks everyone for coming to join us. Staff and students from LBJ and from the UT community at large have often put their considerable skills in research, data analysis, and collaboration to use to work on the wicked problem of homelessness in Austin. This year I've had the pleasure to begin working on a project with two of the people present today, Sherri Greenberg and James Snow, to leverage the powers of smart city technology to help people experiencing homelessness and the agencies and organizations that serve them. Our project is funded by Good Systems, one of the 3 Bridging Barriers Grand Challenges at the University of Texas at Austin. The goal of Good Systems is to design AI technologies that benefit society and reflect our values. Through a competitive process, an interdisciplinary team of LBJ School and School of Information researchers and City of Austin staff won funding to develop tools that use AI to empower people experiencing homelessness. Cities have started using AI and machine learning to predict and respond to any number of things, from traffic patterns to public safety needs to changes in land use patterns. We aim to use this technology to predict and respond to patterns along the homelessness continuum, connecting people to the agencies that can best help them and empower people experiencing homelessness to get the resources they need as quickly and efficiently as possible. Our team will conduct extensive interviews, both with service providers and with people on the homelessness continuum. Using data collected from these interviews and other data sets collected and developed by the City of Austin, we'll use time series and cluster modeling to better understand the factors contributing to homelessness and identify gaps in social services that, when filled, can empower people on its continuum. The resulting AI-based tools will help decision makers identify where services are most needed, how to deploy those services, and offer personalized recommendations to individuals on the homelessness continuum. COVID-19 has shown that responding to the needs of people along the homelessness continuum is paramount, and we have to respond rapidly. Disasters often impact these people and families most intensely, and cities must be agile in adjusting to how they can help. During this panel, we'll hear more about how service providers have adjusted to the ever-changing landscape of COVID-19 to best serve people experiencing homelessness. During this conversation, I know that I'll be thinking a lot about how technology can make this process even better, more proactive and less reactive, more aware of gaps in the system, and more flexible about how and where resources are leveraged. And thanks again for joining us, and I'm looking forward to this conversation. Back to you, Sherri.
Thank you, Michelle. And now I have the pleasure of introducing our two panelists for today. Dr. Audrey Kuang is the Associate Director of Community Engagement and Health Equality for CommUnityCare Health Centers, and also has a joint appointment in the Departments of Population Health and Internal Medicine at Dell Medical School. Previously, she was an assistant professor at the Stanford University School of Medicine and an attending physician and hospitalist at the Department of Medicine at Santa Clara Valley Medical Center. As the medical director for the Santa Clara County Medical Respite Program, Kuang developed an innovative program that gives homeless patients a safe place to recuperate after their hospital stay. She is passionate about taking care of the most vulnerable populations and addressing social and environmental factors on both an individual and community level to improve and sustain health outcomes. She led a multidisciplinary team to coordinate post-hospital care and sustain long-term health, which saved an estimated $6 million in 6 years from avoided bed days alone. In recognition of her groundbreaking work, Kuang was awarded the 2015 California Healthcare Safety Net Institute for Performance Excellence. She will speak first. After that, Mr. James Snow will be our next panelist. He has more than 30 years of private, public, and military experience optimizing value, creating positive cultures, and planting seeds for enduring operational excellence, customer service, and service delivery. He prides himself as a driven and strategic people-centric leader and is known for his unique combination of quantitative and qualitative analysis, business intuition, and situational awareness. His passions are developing leaders, having a positive impact on his community, and supporting his family's many extracurricular activities. As the Assistant Director of the Public Works Department at the City of Austin, Mr. Snow leads a workforce of over 80 full-time employees that supports the department with strategic planning, performance management, and process improvement, also financial management, facilities, information systems management, and development of safety and fleet program management. Over the last 18 months, he has served as part of a cross-departmental leadership team working with the City Homeless Strategy Office, and he oversees the city's underpass cleanup effort. He also serves as a co-lead on the University of Texas and City of Austin Good Systems Project, Smart Cities Should Be Good Cities, AI, Equity, and Homelessness. I will now turn it over to you, Audrey.
Thank you so much for having me. I'm gonna share my screen.
Thank you.
All right, can everybody see that okay? Great.
Yes, Audrey.
Okay, so I wanted, oops. Oh no. It's not, oh, here we go. Okay. All right, well, I'm gonna talk a little bit about how we've been taking care of some of the most vulnerable folks in Austin and how we pivoted during this time of COVID. This is a diagram that I put together after a patient shared with me all the different venues of care that he had been accessing in the last month. And it really shows all the different places that a person has to go to for different services. And that sometimes we ask the most vulnerable and the most under-resourced to navigate a very complex system of care, a system of care that can be fragmented, uncoordinated, reactive instead of proactive, and difficult to access. And for my patient, it felt very traumatic and biased at times. This leads me to my next slide, which is that the average mortality for the general population is 78.6 years. For other conditions, you can see for breast cancer, it's 68, if you're a smoker, it's 68. But if you're homeless and you're unsheltered, the average age of your life is 53 years old. That is 10 times higher than the general population and 3 times higher than a homeless person who's sheltered. So that's very sobering when I think about that. 25 years less than the average person for someone who is sleeping outside and exposed to the elements. But in a way, it does make sense when you think about the system of care that they have to traverse and try to navigate. So in Austin, at our last point in time count, we had an 11% increase in the number of people experiencing homelessness at 2,500. And for the first time ever, we had a increase of those who are unsheltered over those who are sheltered. So it was a 46% increase in those who are unsheltered. And for the first time, it outnumbered those who are sheltered. So to respond to this, we have a very robust team within community care that focuses on those who are experiencing homelessness. And our goal is to provide care that is coordinated, that is proactive, easy to access, and really addresses the whole body, physical health, mental health, addictions. We want to address social determinants like housing, transportation, food access. So we want to be able to be like a one-stop shop to everybody, and we want to go to the patient. So we have a clinic in the shelter. We have a mobile team that goes to fixed sites like churches in our community and other areas. We have a street medicine team that will look for individuals who may be in encampments or under a bridge. And then we have another fixed site called Care Connections Clinic, which is our hub. So that was healthcare before the pandemic. Now with the pandemic, things have been very different. So the first thing to know is that the homeless population is a very high risk group for many reasons. One is that they have poor health. They usually have more chronic conditions in general because they haven't been able to take care of themselves. They seek care in congregate settings, whether it's in shelters or soup kitchens. They use public transportation, public restrooms. They are using areas that are going to be areas where they can be exposed and at higher risk. They are an aging population. 40% of individuals are over the age of 50, and we know that COVID is more severe as you get older. And they also have limited ability to follow public health advice. So at the beginning of the pandemic, we were told to stay at home, wash your hands, socially distance, quarantine yourself if you're not feeling well, and none of that can be followed if you're experiencing homelessness. And lastly, there is stigma and discrimination that individuals experiencing homelessness may not be able to access different types of care because of the stigma that they have. So for this reason, we realized we really needed to step in as providers who are aware of the medical piece, but also as public health servants. So for our response, we addressed screening and testing. We helped with any outbreak and mitigation. We looked at how we can do a better job with surveillance testing, how we can help with the quarantining and isolation, and how can we help with maintaining access. So for the first thing was looking at the shelters. It was very important at the beginning of the pandemic to screen patients for the first 3 symptoms: cough, shortness of breath, and fever. Since then, we know that there are additional symptoms that we need to screen for, but those were the main ones at the beginning, and also to take a temperature. For shelters, this felt very foreign. It felt like, well, we're not medical people. Why do we need to do this? And we really stressed the importance of, this can spread very quickly, and that everyone coming through the door should have this done. So helping the shelters get this in place was something that we were able to help with. In addition to helping educate staff, making sure there were enough hand washing stations and sanitizing stations, physically distancing within the shelter, which meant cutting down on the numbers, and then really promoting mask wearing. And at the beginning, it was still very foreign. Now it seems very common, but in the beginning, it was a little bit harder to do. I want to share the story of 2 shelters. So we have 2 shelters in our downtown area, and On March 26th, this is pretty early in the pandemic, we have a clinic in the second shelter next door. We were able to find that there was a positive case at the shelter. And then within the next 2 weeks, we found 5 additional positive cases by testing individuals. And, being on the front lines, we were able to, know that these cases are coming in and it's getting, it's spreading pretty quickly. So we realized we needed to act quickly. So by the next day on April 9th, we went back in and did testing for the remaining women in the shelter. After the first index case, they moved most of the men out of the dorm that he was staying in, but the women remained. And then we started to see positive cases in the women. So we went back in on April 9th. We tested 39 patients. A third of them were positive and half of them were asymptomatic, which is just, at that time, it was mind-blowing that it spread so quickly. All the women after that were moved out of the shelter number 1 and moved to an isolation facility, and that shelter underwent a deep clean. We realized that we needed to get in quickly to the second shelter and test those individuals as well. So on April 13th, we tested all the individuals at shelter number 2, that was 69 people, and they were all negative. So we feel that the swift action led to limiting the extent of the outbreak at shelter number 1 and preventing an outbreak at shelter number 2. And I think at the beginning of this pandemic, again, everything was so new, we were learning a lot. And I think one thing was clear, that congregate settings were very high risk, that people living in close contact, and now we know jails, nursing homes, and shelters are very high risk. And for that reason, we need to be extra cautious and do surveillance testing. And the other thing was that we didn't realize at that time, we know now that there was the possibility of having asymptomatic carriers. And so that increased the risk and the spread as well. So offering testing was very important. At this time in March and April in our city, most of the testing was available either through your doctor's office or through what we call drive-through testing. So we had set up multiple areas within our city to accommodate cars that could drive through, and we could test them in their cars. But what about individuals who are experiencing homelessness? How will they access these sites without a car? Would we expect them to get on a bus and go to these sites? Definitely not. So we realized we needed to go to individuals to test. So we set up testing sites within shelter number 2 in their garage. We were outdoors, it felt much safer. At that time, we were able to acquire enough PPE. And basically just set up testing, and we continue to do that every 3 to 6 weeks, depending on what we're seeing in our city. We will have a testing day where everyone downtown, whether you're sheltered, unsheltered, staff, volunteers, we will offer you testing. And we recognize that we need to really test frequently to make sure that, catch anything early before an outbreak occurs. So far in our experience, we have found that the yield was highest when there was a positive case identified, but if there were no positive cases, then the yield was lower. We also went to other areas of the city to test. Here we set up some tents at Sunrise Church, which is another area where a lot of unsheltered individuals experiencing homelessness go to seek services. And then we also went to the state camp to offer testing as well. So since March, our team has tested over 700 individuals, and we hope to continue to do this on a regular basis. So the other great thing about that our city has done is set up isolation and quarantine facilities. We have an isolation facility that accepts patients who are known COVID positive or who are under investigation, whether they've been exposed or have symptoms. They can stay there while they're waiting for their test result, and so they can quarantine safely. We have also set up 5 motels in the city for people who are at high risk, for those experiencing homelessness. We currently have over 300 people across these 5 motels. This is just one. And so individuals who are high risk as defined by the CDC, whether their age is over 65, they're immunocompromised, they have COPD and other conditions, can stay here, and while they're there can get other services. So that's something that's been really great for individuals experiencing homelessness that our city has set up. We have sent our medical teams to these motels to provide medical care. Maintaining access was something very important to our team. I know in the beginning of the pandemic, many clinics around us were closed while they were trying to get enough PPE and trying to make sure staff were safe. And our team felt very strongly that we had to stay open. Our patients don't have phones. They can't call us. They can't take a bus often to get to us. So we realized we needed to stay open and continue our services and make sure that they had access. There was a lot of fear and anxiety, especially at the beginning of the pandemic, and you know, normal places that they would that people would access to charge their phone, to use the computer, to take a shower. Many of those places were closed. You know, soup kitchens in the beginning were also closed. So they felt very isolated, more isolated than ever, and very alone and scared. So for our team to continue to provide services was very important. And also recognizing that if conditions got out of hand, they might go to the ED, and we really wanted to maintain access in the hospital, especially with COVID cases coming in as well. So in summary, our homeless healthcare team has played a vital role in the city's homeless COVID response, providing medical services, expertise, and guidance. We played an important role in protecting and empowering the most vulnerable. And I do want to just give a shout out to our team. I'm so proud of them that they have exemplified compassion, courage, flexibility, and resiliency. And the other thing that we saw was just coming together of many groups. We found that you could have an academic, public sector, community partnerships that could come together, be nimble, integrated, and innovative. And the last thing I will say is that housing is healthcare. I said this a lot before the pandemic, and even now it seems even more important that those who do not have homes are affected even more greatly by this pandemic because of all the things that are happening in our community, the lack of resources, and the virus itself. So I will continue to speak for housing as one of the most important things to promote healthcare. Thank you.
Thank you, Audrey. We are so grateful to you and your team working on the front lines and providing healthcare to those who are experiencing homelessness with community care, and all that you have had to do to adapt during this COVID-19 pandemic. And indeed, I think we're exemplifying today this partnership that you've talked about with the city, with community care, with academia, and of course, we know with the social determinants of health that housing is healthcare. And with that, I want to turn over to James, who will discuss the work the city has done during COVID-19 to help address issues with keeping those experiencing homelessness healthy and safe during this time, including sanitation and moving people out of the crowded shelters, as you alluded to, Audrey. Also, he will touch on the research project that he is working on that Michelle mentioned with myself and Michelle and others at UT and at the City of Austin. James?
Thank you very much. And it's hard to follow Audrey. She's so articulate, and she stole some of my thunder about some of the great partnerships we're doing between the city and community care. Thank you for the opportunity. What I'd like to say is about 18 months ago, I started the journey when my dad told me when I was younger, sometimes volunteering brings the greatest opportunities and rewards. The university, not the university, TxDOT was been cleaning the underpasses for many years, working with the homeless population, and their funding changed, so they asked the city to take over it. I was given the opportunity to take over that incentive, and at that time I got to see the more human face on homelessness. The quandary that the city has, or especially my department under the clean strategy goal for the city, is that the underpasses were never created for sheltering people, rather they were created for moving cars and people through the system. But during times of where, as Audrey said, we have a housing crisis, it becomes convenient. So what the city did over a year ago, or more than a year ago, we had a city strategy for addressing homelessness. There's 4 main priority areas in that. 1 is housing programs, 2 is responsive services, 3rd is cleaning strategies or clean cities, clean strategies, and communications. I fall under the clean city strategies. But also, I was given an opportunity to work with Sherri. In February, it was just funny, just before this all hit, Sherri and I met at just by accident at a good services, good systems thing, and said, let's work together. And then obviously March happened. The city adjusted our program based on that. I am going to provide a couple documents so they can be posted later on the site. three key documents. One is the July 22nd report that came from a consultant talking about how we're managing as a city this issue. And second, the September 11th update to give you exactly what we're doing under these conditions of COVID. And then finally, a project charter that we're working on, which you'll see all of them connect. But let's talk about what we're doing currently. Well, Audrey alluded to one of the things. One of the first things we did was we developed facility structures. At this time, we were able to utilize and partner with some of our hotels in the community and provide two sorts of shelters. One is an ISOFACT, as it was talked about, which is really for any population coming in that could possibly consider risk and bring them. But then we also set up specifically the pro lodges, which were set for our homeless community, because they're high at risk, as Audrey showed us, and that we needed to give them an opportunity to shelter, and because obviously you can't just shelter in place in in certain areas in the city. This also follows suit as what Los Angeles has been doing as far as their lock key program. So the city took the similar idea and worked through. Luckily, we've been forwarded through good city management, community partners. I think we'll be able to extend a little bit farther than Los Angeles, but still doesn't address the overall issue of the housing shortage that we have. The second thing we were able to do is we actually been able to leverage the CARES funding that we've been given. The city was awarded $171 million. The city council looked at it and considered being a good community partner that we could move some of that money to continue the services. Our neighborhood housing and community development group actually used some of that money for the rent program, because what has happened during COVID is the homeless population has changed. Because so many people became unemployed, we've seen an increase of people underneath the underpasses and other areas. Now, instead of being in tents, rather they're in their vehicles, because that's one of the few things they have. And it provides different growth to the population, but also addresses the need that we've always talked about, is that the lack of housing. Our downtown community court has been working really hard during this time. And this is one of the challenges. Today, we can reach out and talk to people through technology. But one of the things, especially dealing with the homelessness, is a lot of the personal touch. They don't have the technology. They don't have the capability to have that personal touch. Now, what the city has done through the DAA, or excuse me, DACA, is that we actually give them cell phones, the opportunity, so a prepaid cell phone, so that they can actually have a reach that way. But we've also been established the Terrazzo Library as a case management program area, so that they can come, because a lot of the homeless obviously is downtown, so it's a closer walk to them to get to those services. One of the things, though, with us and a lot of the community providers is that we stretched our services because of this time. Not only have we increased, but also it's diluted some of the places where people have been. Even though you would think the ISOFACTs and the pro lodges would help us congregate services, the problem is that we didn't have the resources to shift, or extra resources to shift. So we had to shift resources. So some of the services levels went down because of that, because we had to move services that were working on the streets to the hotels to work with the people. The hotels only provide about 360 rooms. So obviously we still have a large population that still needs to have service. And like I said, it's been growing. We do, and I think on one of our attendees today is one of my partners, Andy Hoffmeister, who's assistant director for EMS, and he works with the host team, which actually is downtown in the local area working with the people, but they've been challenged just like their paramedics, because again, there's increase of population, but also, as you saw in the photos that Audrey showed us, it's a new world in which we're dealing with. They're having to have PPE, they're having to worry about different things going on that allows that natural human touch and be able to provide people the services they need. The city has put up at this time food access, which is very important. We have the Eat Apart Together initiative, which we actually serve millions of meals down to those areas, because obviously the people, a lot of things have closed, a lot of the restaurants have closed, and capability for people to get food. We thought that was a way to partner. We partner with nonprofits on that. We also have a homeless priority communication team. Laura Foss, who works with our corporate PIO, has been leading that strategy and working, because at this time too, during these times, to be able to get the message out and talk to the people and let them know what's doing. Because at these times, I find that during crises like this happen, we see both the good and misunderstandings in our community. And this gives us an opportunity to communicate and probably break down some of those silos and get a good message. I work specifically under the public space management, which is the parks, the underpass and such, where a lot of people culminate because of that. It does bring a health risk, because in the clean city strategy, some people think it's inhumane, some of the things that we do, but the thing is when someone drops off a couch or mattresses and everything, that's where fleas and mites come, different things come. And also with all this accumulated trash, and we stop for about 2 or 3 weeks, what happens is we start seeing an increased rat problem. We start seeing a lot of different things that unfortunately those people, like we said, we can only house 360 of them. All those people now have not just the COVID, but other diseases out there they had to worry about. So we've been working with them, especially since June, not only talking to them, but looking at how we can address the strategy we've been using for the cleanups to make it so that it's not disruptive. Because one of the city's goals during this time is not to move people. And if we do, it's only because of a health emergency or some type of emergency that we have to move them. But we are trying to find ways to do that as best as possible. And then also we have established the homeless service division under APH for the city, and who's looking at a citywide systemic approach. As I mentioned, the city was able to contract with a consultant to look at how we're doing our approach. And now what we're doing is we're using a systems approach of the way that we do things to make sure that we can systematically do things well, but also we've done a public-private partnership, or what we call a P3, because we think homelessness is a community issue. It's just not a governmental issue, which a lot of people put. And we together as the public sector, working with the private sector to see how can we leverage resources and funding and be able to provide some of the services necessary. But now let's talk about services. I was lucky in February to start talking with Sherri about an idea of saying one of the biggest challenges, COVID, non-COVID, was connecting the people to the wraparound services. Housing is just one part of this, but it's also getting those people into those housing. And also at that time, taking that snapshot to help some of this vulnerable population, providing other services. We've always had that disconnect. So what we were able to do was put together a great team. And I take a lot of pride in that team, not just because I'm part of it, because we had such an outreach. When Sherri and I started making phone calls, there was no no's. It was like, can I join and can I bring more friends to the table? Because we all see this as a serious issue. And we've had partnerships that you just didn't think was possible, but they came to the table. And the reason why is because of the goal of the study. Because what we are trying to do is do that connection. What we're trying to do is use AI as a capability to take all these different data sets, both qualitative and quantitative, put them together and actually be able to help the people who are trying to help the less fortunate connect. With the AI project, what we think is that we can take those data sets, not only help connect those individuals with the services, but also help the providers like Audrey be able to connect more currently and frequently, and be able to let them see certain indicators that say this population might be falling into that continuum, and maybe there's a way that we can help them. So I'm excited about the project. I'm excited about talking to you all about this, and I'm excited about being part of this team. But thank you so much for letting me speak so much. I'm not used to that. I'll go back to be the timid public servant that I am. But Sherri, thank you very much for letting me talk today.
Thank you, James, and thank you so much to you and your whole team and all at the City of Austin. The creativity that you have been exhibiting is really an exemplar, and the work that everyone is pulling together. At this time, we'd like to provide an opportunity for questions, but I have one that I'd like to start off with for each of you, and that is, what do you see as the lasting changes? So Audrey, for you as a healthcare provider, are there lasting changes that you see? And then James, for you, with the work that you do with the city, are there lasting changes that you see as a result of the COVID-19 pandemic? Audrey, I think you're on mute. There you go.
So yeah, I'll go first. Thank you. I think that the crisis did force us to work better together. As much as I saw how much we were siloed and tried to fight it, it still happens naturally because you're in your world doing the work in front of you. And so as much as I was trying to fight the uncoordination, sometimes we kind of naturally slip into it. But this pandemic forced us to really, band together and share our resources. And, and I really appreciate what James was sharing about the communication piece. I think that At the beginning of the pandemic, ECHO and the city of Austin helped coordinate a call with all the service providers 3 times a week. Actually, it was almost every day, then it went to 3 times a week. And just sharing like what soup kitchen is open, who's providing lunch, who's got PPE, what street team is out. That was so critical at the beginning so that everybody knew what was going on. And I remember at the beginning, there were over like 80 or 90 people on the call. So that communication was so critical and wouldn't have happened otherwise. And so I hope that that continues, that we continue to talk and share resources. And I think with ECHO and the city working together and all these other agencies that hopefully that will continue on. We pivoted our team. I mean, we always had a street medicine team. We had our fixed sites, but we realized with the pandemic and we're expecting everybody to shelter in. We don't want you to travel if you don't have to. We really hope to expand our street medicine team and continue to go to people. And so we're looking at more sites of, where can we go? Where are the people and where can we go? And then the last thing, this is my own personal opinion, but the pro lodges have been so wonderful. Before the pandemic, when people came out of the hospital with a broken leg or even if they wanted to have a cataract surgery, they had no options. It wasn't, you just couldn't. And as a healthcare provider, feeling stuck and hopeless in that situation, not being able to, knowing the right thing, but not being able to give it to my patient it was just so disheartening. With the pro lodges, I know they're not forever. I hope that maybe we can keep one. We have 300 people, at least 300 people in them. We have a wait list of another 350. And these 350 are not just, these were chosen by the community as very high risk, all meeting CDC criteria. I have had patients who are at the Pro Lodge. One lady I saw on Monday in the clinic who had both of her cataract surgeries done while she was at the Pro Lodge. I had another guy who was able to get his colonoscopy, which he would have never gotten. I know it's not the perfect time, but I mean, he's now in shelter and he's taking advantage of being in shelter. So now that they don't have to just try to figure out how to survive, they can start to address other things in their life, like starting to think about their health, think about benefits that they never thought about applying for. And so that's been really encouraging. And so while there's nothing set in stone, that's one of my hopes, is that we can continue to have some place for people to be safe and work on some of these things.
Thank you, Audrey. I know how important that respite care is, and that community care, in fact, has I think about a dozen respite care beds, but obviously that's just not enough. James, how long can people who are experiencing homelessness stay at the pro lodges? Is there a limit, and do you know what the future is?
Well, I can't tell you what the actual criteria is for moving people. It's on a case-to-case basis. Some of those case managers I talked about in community court are there at the pro lodges helping with that, because their normal activity is getting people into rapid housing or long-term permanent housing. I will tell you that what's interesting is when crises happen, people see it as a crisis. I see it as opportunity. I think this gave us an opportunity as a community to come together to shine light on an issue that we've been trying to figure out how to handle. And I think it brings us all together to say, how do we address the issue? Prior to this crisis, the city was already looking at buying a hotel and putting services in, and we're actually, we're in the process of doing that. Public Works, actually, their architectural project managers did the evaluation, helped put that all together. And what's interesting is this crisis gave us the opportunity to actually test out the theory, because a lot of people put things on paper, but we actually got to see what was the real resources necessary to do it through the ISOFACs and the pro lodges. Because everybody said, well, it'll be wraparound services. Well, what does that entail? We also noticed that there's a shortage because we only have limited resources right now to address in the healthcare industry as a whole. Now we're gonna say we have to pivot or shift some of those resources to help, but that still leaves a hole in the current resources. So now we have to have the discussion of, it's just not putting up a hotel and letting people stay there. What is all involved? And what is the wraparound services? So this actually gave us what I like to do when I've done project management, a proof of concept of really taking the theory to real world and saying, what is it gonna take? I know the city's looking at other opportunities to expand the one hotel that we have, as far as, and that's a permanent hotel that we bought and we're putting into place, but now we're looking at a second. And I think what we've been allowed to do is again, we've got a better idea of what we're dealing with, what we're signing up for as a community, and also gave us the opportunity to stretch out to private partnerships to say, help us solve this community issue, and it's just not leave it on the hands of government. So I think, again, I get to meet interesting people like you and like Audrey, and just shows us that no matter where you come from in the world, no matter what you do, we can come together and solve some of these big problems.
Thank you, James. We've been discussing data, and I think one of the issues is, how do we get the data? How do we identify people who are experiencing homelessness? So maybe you can talk, there's the point in time count that, of course, Austin and many other cities are participating in. If you all can describe the point in time count. But Audrey, I also know that at Central Health and at Community Care, we look at a broader definition of people experiencing homelessness. So if somebody comes in and self-identifies, so maybe we can discuss some of this data.
Yeah. I absolutely believe that that we need more and better data to help make decisions that that are, I guess, evidence-based. That has been a big challenge from where we are, but we want to continue that. One of the great things about this pandemic was that we were able to start to collect this data. As I mentioned, we had 350 on the wait list. We were able to identify 35 people with HIV on the streets who are not in care. How many people are on dialysis on the streets who could easily apply for Medicaid but don't know how to do it? And it's sort of a grassroots effort that came about because we were taking referrals for the Pro Lodge, and we needed to get some basic information. And now we're sitting on all this great data, and we're trying to figure out, well, now what do we do with it? How can we use this to better our patients and find them? So yes, we do have the point in time count. And like you said, we have expanded our definition. When you ask an individual, are you homeless? I know 50% of the time you won't get the answer, because whether it's shame or embarrassment or they don't want to talk about it, a whole host of things. So we've learned to ask, where are you staying? Do you feel safe? And we will then find that they are staying with a cousin and it's day to day, or staying with a spouse who's abusive and very tenuous, or there's 10 people in an apartment and they can get evicted at any time. So, when you expand that definition, you do find that it's much greater. So that point in time count is truly just the street homeless and sheltered. And if we were to ask it in a different way, I'm sure we would find much, much more.
Thank you, Audrey, for adding that, because as we've talked about, there's this continuum of people experiencing homelessness, and it may start with an individual who's couch surfing, right? And then after 30 days, they're no longer able to couch surf with someone. Then what happens? And all the way to a situation where they are sleeping outdoors and then identified in that point in time count. But that is just a specific definition and a specific population. James, have we been seeing, and I think you spoke to this, in fact you did, more people who are experiencing homelessness, and they may not be sleeping outside under the bridge, but they're sleeping, as you said, in their cars. So is there a way that we're gathering data so that we know the extent of the folks who are experiencing homelessness?
Thank you, Sherri. One of the things, yes, we are. What the city has done is we've collected or created these GIS collector apps. So whenever we do services for Public Works or Watershed or Park, we actually collect the data of who's there. We don't take names or anything like that because we don't think that's important. It's just the count and data as far as who's there, what they're experiencing, what are we seeing. Now, I do appreciate the opportunity to talk about our project, because I think our project's very timely. Because what I've noticed in this, and I think Audrey mentioned it, is there's a lot of people collecting data, but we're not connecting those separate data sets. And with our project, with Good Systems, what allow us to do is actually connect those data sets. For the first time, I think a lot of community members are coming together and saying, let us share all this disparate data. And, and using AI allows us to sift through certain things that the normal human eye would just say, oh, I don't see any connection to, but we have the capability to make those connections and also turn over that information to the people who need it the most, like Audrey's group, like other service providers that are trying to do this. and also allow us to touch those people that need us the most. That's what I have noticed in this, is that we have a great opportunity here to bring data together. But also what I talked about earlier, what I think is important, and we have this opportunity is this partnership, is you can always get the quantitative data, but we also have the opportunity to get some qualitative data. With the ability of talking to some of the people in the pro lodges and such like that, we can talk to them and get their true stories. Because data can only tell me part of the factor. The qualitative actually helps me tie it together and make sure I have the right data sets. Because I can, as I was explaining yesterday in a meeting, I can have, unless I know what the outcome I'm trying to achieve, I could be looking at the wrong data. So this way, AI gives us an opportunity to pierce into that and see that. So I'm very excited that Good Systems gave us this funding to work through this as a partnership, because I do think it's going to be not only timely, but I think it will do what you asked about, is I think it will set us further us down the path that we're trying to get to. And actually, technology has once said that all it does is speed up problems. Sometimes it doesn't assist, but I do see this opportunity that it'll actually help speed up the solution to the problem, which we're all working so hard to do.
Thank you, James. Audrey, I do see a couple of questions from those who are participating in the audience for you. And the first one is, we've alluded to the point in time count. Can you talk about how and when this is conducted, the point in time count?
Yes, this year it was done on January 25th, and it's done across the country in all cities, because a lot of the federal funding is tied to the numbers that you get. So we usually choose like the third Saturday in January, and this is done across the country. ECHO is the one who is organizing it in our city, and they do a fantastic job months in advance, getting volunteers, setting up, quadrants or sections of our city, and making sure people are, getting as much area covered as possible so we can be as accurate as possible. And I can't speak to how quickly the data, I don't know much about how that data, then what happens, but I know ECHO then, you can Google our point in time count, their report is up. And I think it usually takes a couple months, but I'm not sure.
I would like to bring up something real quick. It's not the point in time count, but the city has stopped our services. Well, we, working with the census, has postponed our services for the next 2 weeks, starting last week and this week, because that's other critical data. Is we stopped the service because we didn't want to have any opportunity to possibly temporarily displace someone, because the Census Bureau is going right now through the city of Austin and doing a very thorough, because we need that data too. Because that data also gives us other grant opportunities and other federal assistance will help this program. So I think the point of count is very important, but at this time too, I hope everybody understands that that census data is very important to us in the city. And if you haven't taken it, you need to. I know the volunteers, I was on the call last week. The volunteers are out there, are forced to all the different locations, and we need to get that data too.
Absolutely, James. It is critical. Please, if you have not participated in the census count, do so now, because that is critical, and it's a way that we can access additional funding. Audrey, I see another question for you, and this has to do with those healthcare workers who are providing healthcare right now. And are there shortages as far as healthcare workers who are providing directly the healthcare? And do we see a fatigue among those? And is this greater with those healthcare workers who are providing healthcare to people who are experiencing homelessness?
Yeah, great. Thank you. I know at the beginning of the pandemic, there was just a lot of fatigue. It felt like we were in a sprint, and there were so many unknowns, and just trying to figure out, how are we going to help our community maintain access. So there was certainly fatigue. I can only speak for community care, but they are wonderful about, making sure that we were safe, that we had enough PPE. If anyone had any medical conditions, we could find, ways that they could participate with contact tracing or calling patients with telephone visits. They have given us some recharge days off to make sure that we take care of ourselves too. So I can only, say nice things about community care. I will say for our team who take care of very vulnerable patients, it can be very traumatic. We often talk about compassion fatigue. And I say that because, you know, we're watching, we have a front seat to this kind of terrible situation unfolding for our patients, and often we feel very helpless and unable to do anything, and that can be very traumatic. And so we as a team have, you know, it's never easy, but talking about it, sharing resources, you know, being able to share, you know, some of our frustrations have been very therapeutic. And so I know among those who do homeless for healthcare for the homeless, and there are many great organizations across the country, that's something that we often talk about is recognizing the challenges of working with a population that is so vulnerable and feeling sometimes helpless to do things. But, you know, we all have a patient that kind of keeps us going, that is very positive, that we feel like we were able to make a big difference, and you kind of keep that in close to you so that it keeps you going, so that you can find that next patient where you can really make a difference.
Thank you. We appreciate your compassion and, of course, the empathy, and it can take a toll. So we certainly are supportive of all that you do. And I think it's very important right now and moving into the future that we have an understanding, all of us, of what it takes, right? And that we collaborate and continue to collaborate on providing services and collaborate among the different sectors, as we're doing here today, with the public sector, with healthcare, with academia, with bringing in the private sector, as you have mentioned, that this is so important. And certainly at the LBJ School of Public Affairs, we want to see real world impact, right? And I think that what we're talking about here today is the real world, but also showing, as Audrey, as you and James have noted, the impact that we can have when we work together, when we are evidence-based, when we use data, when we pull together, and how seeing that difference that we can make in people's lives can pull you through and can keep you going. So I thank you so much for all that you are doing. I think we may have time for one additional question before I close out. And that would be, I think for each of you, just if you have any closing comments that you might like to make before we close out today. Audrey?
I might let James go first as I'm collecting my thoughts.
James, is there a closing comment that you would like to make? And you certainly don't have to, but I wanted to give you that opportunity.
Audrey, I so like following you, and now you're putting me on the spot. I will tell you, I see some things in the chat. What heartens me is the way the community has come together on this, and like you said, you know, and been able to work together no matter what silos. Actually, we break down a lot of silos at this time and work together. I do agree with you, Sherri. One thing that I think is important with the work we're doing is we are resource limited. So by utilizing AI, we'll actually be able to put the resources to the best use and get them to the places they need to be. I do appreciate I'm looking at the chat, some people asking about certain things as far as, yes, there's been an increase of homelessness at this time because of the loss of jobs. As I mentioned before, people are asking, I'm reading here about the porta potties and the wash stations. That was things that we did out there to get to those people because at this time they need it. But the one thing I ask, and people want to volunteer, we are starting a pilot project to work with the community as far as the cleanups. But if you could just kind of hold off from some of the volunteering until we get that going, because the unfortunate thing is some of those areas, there are needles, there are other health hazards that people aren't prepared for. And the other thing too, as the City of Austin, we've done is all our employees and contractors that actually address that, at least in the underpass, go through a special mental health training, understanding that we are going through a very vulnerable population, making sure that they're prepared for the stress and things going on. It's just not coming and picking things up. It's actually understanding who we're working with and making sure that we can reach out to them in the right way and not be disruptive of their nature, because consistency is important right now for them. And even though it's good intentions, everybody wants to come out and help, those good intentions can sometimes put people off and make them feel uncomfortable. So I do appreciate all the charity that's out there and people trying to do, but if you could work with us, you could work with Audrey's group, and we can do a lot of things better because we can get you in the right places so you can do the best good and your good intentions don't go unwarranted.
Thank you, James, for those helpful pointers. And there is a question, and this would be another conversation, but we can point some people in the right direction. There's a question about any measures that are ongoing to help people who are on the edge of this homelessness continuum. And I know that the city is working with various nonprofits and providing funding and also some rental assistance. So perhaps, James, we could add some items to the website when we're finished because we do provide this opportunity with our In the Arena series where we provide additional resources for a deeper dive for people. So if we could provide some of those, I think that'd be helpful.
And in some of the documentation I'm going to give you, it specifically talks about that rental act that we have, and let you know more about that. But some of the documentation I'll provide will give people some ideas of where to go. Wonderful.
Thank you. Audrey?
Yeah, just some parting thoughts. I think that this pandemic has really highlighted the intersection between health and housing. And unfortunately for those without housing, it's really highlighted this gap and lack of resources and disparities. But like James said, with us coming together with our resources, with our data, I think it has paved a way for potentially some really great things. So as terrible as the pandemic is, I am excited about some of the neat things, the partnerships that we have seen come out of it, the improved communication, the pro-lodges. And so I know the pandemic's not going away anytime soon, but I'm glad that we continue to work together. So thanks so much for having me here today.
Well, thank you. Thank you, James and Audrey for joining us today. And thank you to Michelle for helping with the project. And certainly I look forward to continuing to collaborate with you and with others in our community. And I want to thank all of us from our community and from wide and far who have joined us today for this In the Arena. And also, I hope that you will join us for our 50th anniversary celebrations that are coming up. You can find them on the website. So with that, we will conclude for today. And I look forward to continuing the discussion and the dialogue. Thank you so much, everyone.